Hello, everybody, and welcome to one of our webinars with Immunity Canada. We are very excited to start this webinar today. Welcome to our Autoimmunity and Primary Immunodeficiency webinar today. For those of you who don't know me, my name is Andrea. I am a board member for Immunity Canada, and I am the mother of a boy diagnosed in 2019 with a DGIT, or severe combined immunodeficiency. This is our second webinar of our spring series around the importance of learning about immunodeficiency. And before we get started and I pass over to our presenter, I'm just going to do a few housekeeping notes for everybody here today. So first, I would like to welcome everybody and do our virtual land acknowledgement. I just want to be here. There you go. Immunity Canada acknowledges that from coast to coast, we are the guests of the ancestral territory of Inuit, Métis, and First Nation people. Members are encouraged to consider their own position and relationships to the land where they find themselves as part of improving our own understanding of local Indigenous people and their cultures in a spirit of reconciliation. Who we are, for those of you who may be joining us today for the first time, and also for all of our members who this might not be their first time. We would like to start by looking at and reminding ourselves who we are as an organization and why we are doing these types of events. Our mission is to empower Canadians impacted by immunodeficiency disorders to live well through education, support, advocacy, community building, and research. As well, our vision is that all Canadians with immunodeficiency disorders have access to the resources they needed to thrive. Our values are community, equity, inclusiveness, empowerment, excellence, and innovation. We do encourage all of you joining us to take part in this webinar, and if you can talk as well, we thank you all of you for your participation as well. You're going to see that we will have a Q&A at the end of our webinar, and we encourage to all of you to submit your questions. There is here the Zoom chat. There's an option for Q&A. There's a Q&A function. So if you are having any technical issues and you find yourself unable to do so, or you're not really sure how to, you can email us. And we will be checking our emails as well to answer any questions that you have. And please note that this session is being recorded. Only myself and Dr. Harville will be seen on the recording, but questions from the chat that you type in might be read out loud. So if you have anything that you might not want to ask, or you are afraid, or you're a little bit embarrassed about it, you can also mention that in the info box. I will make a disclaimer that we use with all of our events in Immunity Canada, that we are not a medical organization. With that said, views and opinions by our guests as speakers don't necessarily reflect the views and opinions of Immunity Canada. So please do not also substitute any of the advice from your physician or other qualified health providers regarding your medical condition. For those that are in our events, also please note that Dr. Harville, who is with us today, he's not able to give any personal medical advice. So please, when you do, put a question and note that he will not be able to respond to personal diagnosis or medical, and share medical opinions or personal medical advice with all of you. So that's our disclaimer. I'm sorry about that. So I want to welcome Dr. Terry Harville. He is an allergist immunologist based in Little Rock, Arkansas, and is a medical director of the Special Immunology Laboratory at the University of Arkansas for Medical Science, a consultant for immunodeficiencies, autoimmunities, and transplantation, and a longtime advocate for holistic whole person care. He is a board certified in 4 medical fields and has done much of his clinical and research in evaluation and treatment of patients with immunodeficiencies and autoimmunity, post-infectious immunocreative disease, organ transplantation, and hematopoietic cell transplantation, investigations in immunoglobulin treatment for autoimmunity and immune system dysfunction, investigations regarding autism spectrum disorder and post-infections encephalopathy. Some of you might recognize Dr. Harville from past events with us, as he has spoken for us at our national conference in Ottawa in 2023, and in Calgary in 2016. We gladly welcome Dr. Harville back with us today virtually, and we're really excited to have you. So now I will just stop my sharing my screen with all of you and hand it to you. So welcome, Dr. Harville.
Thank you so much. And I appreciate the invitation from Immunity Canada, and always appreciate providing information. As we've discussed separately, that we know that patients that have immune abnormalities are wanting to know more and understand more about what's going on with their issues and problems. And I think it's important for people to become knowledgeable so that they can self-empower in order to make sure that they're being taken care of appropriately. As mentioned, this is going to be a discussion of immune deficiency and autoimmunity. And let me begin by pointing out that the way we traditionally thought about these things has been very straightforward concept: autoimmunity, high immunity; immune deficiency, low immunity. It turns out, though, that this is not really correct. They're both parts of dysfunctional immunity, and you can't separate them into high or low immunity. It's dysfunctional immunity. Indeed, now we are moving away from using terms like immune deficiency and primary immune deficiency and autoimmunity, and starting to use the terms of inborn errors of immunity, or IEI. And as time goes forward, you'll be seeing this utilized more frequently and commonly to describe what's going on, since it better reflects the situation. There are no financial obligations with anything I'll be presenting today. The things I will be discussing are based on my years of interpretation, of seeing patients, reviewing the literature, doing research. One of the problems is anytime any of us are talking about things, when we say something, it may sound different from what somebody else is saying just by the way we state it. And so make sure we clarify that. If it sounds different from what you're hearing from others, to make sure that we're all on the same page as that goes. We only have so much time. And so I'll be condensing things as best I can and highlighting important issues. Hopefully, I've not overlooked anything that's very important, and very hopefully I haven't left out anything that's necessary to be talked about, but I can't cover everything. And so we can start with what the conclusions really are. In general, the processes that we think of that are causing the problems with autoimmunity, so the immune mechanisms and the immunity issues, are the same as that occur in a normal person as well as a person with primary immune deficiency. And that treatment should be geared towards maximizing the benefit for the immune deficiency and then adding what else is necessary to control the autoimmunity. Indeed, in many patients, maximizing the immunoglobulin replacement therapy can take care of the autoimmune manifestations. Unfortunately, though, things are always more complicated than what we'd like for them to be. Now we have nearly 500 genes that have been identified that cause immune deficiency autoimmunity. And both of these may be present in the same individual. That is, the same gene mutation can be causing immune deficiency and autoimmunity in the same person. And one of the things that we've found out about this or noted about this is that sometimes the autoimmunity will occur first in someone. For example, we have patients that begin with inflammatory bowel disease as teenagers, and then as young adults get diagnosed with having antibody deficiency disorders, or CVID. And it turns out the genes that are causing that are related to causing both conditions. And this is just a handful of these that we're discussing. And over here on the left, I've listed the names of the genes. In the middle, the type of immune deficiency associated with it. Note that almost all of these deal with antibody deficiency of one form or another. And then the types of autoimmunities that are occurring. And primarily, they're hematologic type of disorders, as well as gastrointestinal disorders, some kidney conditions. But overall, it has to do with problems that occur with the intestines and the hematopoietic system. So having problems with your blood counts, or having vasculitis occur, having thrombocytopenia, or other types of related issues. And once again, maximizing the immunoglobulin therapy may be the way to take care of both of the issues. Another thing that's very important for both patients with immune deficiency as well as those without is what we call the HLA locus. Is the most highly associated. So found here on the short arm of chromosome 6. So these are all the chromosomes, and that these are sites, what we'd call hotspots, that have been associated with having autoimmune conditions. And you can see there's some here on chromosome 1 and down here on chromosome 10 and so forth. But chromosome 6 is the most highly associated, and that's the HLA locus. And I'll be explaining more about why that's associated with autoimmune disorders, because it has a critical role in the way the immune system develops. And just to give you an example of this, it's a condition of celiac disease. And many of you have probably heard about this, and this is where people have problems with eating wheat, specifically the gliadin or gluten protein found in wheat, barley, and other grains. And if you've inherited these specific HLA types, and I know that this is a complicated type of nomenclature, but let it be that these are the types that are associated, that you have a 1 in 7 risk of developing celiac disease. Celiac disease occurs in 1% of the population. And again, if you've inherited these, you've got about a 1 in 7 chance that you will be developing celiac disease, whether you have an immune deficiency or you have normal immunity otherwise. And so let's go back a little bit and try to cover the ground. Who develops autoimmunity? Well, it has to be with the genes. So we were mentioning some of the genes a few moments ago that can cause immune deficiency and autoimmunity, and the HLA components that are associated with it. So those that have inherited the components that can cause a problem or susceptibility, and then undergo some kind of developmental promoting factor. So people that have inherited the specific HLA components that eat wheat then may promote themselves to develop celiac disease. This process is occurring whether you have normal immunity or immune deficiency. And so both can exist in the same individuals. And now, again, we've identified about 500 genes that are associated with both of these. And that sometimes we start out, as I was mentioning, with having autoimmune manifestations and not have what appears to be an immune deficiency. And this actually delays the diagnosis of immune deficiency. Right now, it takes about 9 years from when the first symptoms of an immune deficiency occur until the immune deficiency is diagnosed. And so once again, these are problems with dysfunction of immunity, that the true term would be inborn errors of immunity. We have dysfunction of the immune system fighting infections, which would result in immune deficiency, or dysfunction of immunity. It reacts with self-tissue and results with autoimmunity. And one of the other good things to consider about patients that have underlying immune deficiency, especially they're starting with more severe immune deficiency, is that sometimes the autoimmune manifestations can be a little bit more difficult to treat and control because of the greater extent of dysfunction of the immune system. So overall today, I hope once we finish with this presentation, you'll have a better understanding of how the normal immune system develops, how homeostatic features are trying to maintain a balance. So we're trying to maintain a balance between inflammation, anti-inflammation, and prevent inflammatory processes and autoimmunity from occurring. And then to understand when this balance is awry, that we end up with inflammatory symptoms and autoimmune disease. So the first question is, why is there immunity? Well, the textbook says it's for self versus now self-recognition, but that's not really true. It's sort of a concept of what's going on, but it's not really the way the immune system is working. The real reason we have an immune system, though, turns out to be reproduction. But that's a different story for a different time. If somebody has a question about that, I can answer that in the question and answer period. The reality is the way the immune system works today in every organism that we know of is self-recognition. And that involves the HLA components of self as well as self-antigen. And these are being presented to T cells. And the T lymphocytes are looking at this as a password coming from the cell of the body or a barcode or however you want to think of it. As long as the T lymphocyte can recognize this password or barcode, it says there's nothing going on with that cell, I can move on. But if it's not self there, then the barcode, this password is not being read correctly. And that initiates a cascade of events that starts activating the T lymphocyte to then act on that cell that's got the misreading information. And then that initiates an immune response and helps to control the infection that's occurring. The problem is when the immune system misreads that and starts acting against self and then results in self-reactivity or autoimmunity. We have a lot of ways to try to prevent this. We're producing millions of different T lymphocytes and B lymphocytes constantly in our body. We would hope that each one would have the capacity to recognize a foreign protein they can bind to fight off an infection and also recognize self appropriately. And so some of the ones that are being produced do that. They're useful. They recognize self appropriately and have the potential to recognize something foreign that can provide us with normal immune protection. Some of them that develop are useless. They can't recognize self appropriately, and therefore they could never be utilized to recognize something foreign. Some of them recognize ourselves so tightly that they start an activation cascade, and that would result in autoimmunity. And so our body goes through a process to try to eliminate these. I call this the Goldilocks rule. And we try to discard the useless and too tight binding T lymphocytes and B lymphocytes and keep the ones that are just right. And this is a diagram to help illustrate what's going on a little bit further. Up top, we have a B lymphocyte. It has several co-receptor signaling molecules, as well as a cytokine receptor, in this case, IL-2 receptor, that's involved with signaling, cytokine being the messengers that go between cells to help activate the immune system. In the middle here, we have the HLA component with this big A recognizing the antigen sitting in the HLA that's being presented. On the T cell that's looking at this, we have the T cell receptor with the alpha beta components looking at what's being held by the HLA, so binding with what we call cognate interaction with the HLA component, and looking to see if it recognizes the antigen as being self or non-self. If it recognizes it being self, it then decides the password is correct and goes on. If it doesn't recognize it as self and has a component that can bind to that's present, then it stays for a long time. That starts the co-receptor signaling, then starts signaling through internal components of the T receptor complex that tell the nucleus to get activated, and starts activating cytokines through the cytokine receptors to become an activated T cell to then try to fight off whatever the infection is that's occurring. And this is what the T cell is looking like. So looking down on top of the HLA component, we have in pink what are called alpha helices. It's sitting on top of a beta-pleated sheet, the yellow and blue and white, with the green being the peptide that sits in the middle there. Some people think of this like a hot dog bun, with the bun being the HLA component and the hot dog being the peptide in the binding groove that the T cell receptor is going to interrogate to determine whether it's self or non-self. And this is what it looks like when we have the HLA molecule here in a stick figure holding the antigen in the binding groove and the T cell receptor cognately binding to the alpha helices. So it's recognizing the HLA saying, I recognize you as part of me. And now it's interrogating the molecule that's sitting in the binding groove and determining whether it's self or not self. And if it's self, it says nothing going on here, move on. If it looks like it's non-self, then it will start the activation cascade to activate that T lymphocyte to fight the infection off. If it makes a mistake and starts reacting against something self, then it would result in autoimmune disorders. And to help with this during our developmental processes, and again, back to looking at something like the IL-2 receptor, the IL-2 being a cytokine used for signaling, there's a receptor, there are components that are utilized to transmit the signal to the nucleus. And so, as was mentioned by Andrea, who has a son with SCID, one type of SCID has a problem with this gamma chain of the IL-2 receptor, and it malfunctions and can't transmit the signal. Another type of SCID has a problem with the JAK3, where again, it can't transmit the signal appropriately. But we all have polymorphisms that alter the amount of signaling that occurs. So that's why some people react more quickly than others do, because they have a little bit stronger tendency for the signaling to occur than others do. And this threshold for this activity is going to determine how this T lymphocyte that is developing is going to be selected. So let me show you that on the next slide. And so we have a developing T lymphocyte in the thymus. And if the T lymphocyte can't bind to the HLA component, it's going to end up dying from neglect because there's no signal saying, keep me around. If it can recognize HLA in every protein that our body makes, it's going to be retained as having potential to recognize something foreign that could be utilized to provide us with protective immunity. If it binds to the HLA component or to the self-peptide that's presented in the HLA too tightly, it activates in the thymus prematurely, and then that results in apoptosis or killing off this activated cell. So the goal is to keep the ones that can bind just right to self in order to provide potential for those that can bind to something foreign and be activated when it binds to foreign to provide us with protective immunity. But if we alter the threshold for the co-receptor signaling, so like the IL-2 receptor, if we change the way it's signaling, either too little or too much, then we're going to change the type of T cells that are being selected. If we have too little binding, then we're going to select useless T cells that provide us with no benefit and just waste energy. If, on the other hand, we select for those that can bind too tightly, then we end up retaining cells that can cause autoimmunity rather than being killed off when they should be killed off. And so in either case, we retain cells that provide us with harm rather than benefit. And I'll come back to that in a moment to explain more about that. B lymphocytes undergo a similar process, and again, a complicated slide that just gives you an idea that there's signaling occurring on the outside of the cell that goes through signal processes, so multiple steps that will eventually activate the nucleus to tell the B lymphocyte to start making more antibodies against whatever the antibodies are being made for. And so it's a threshold that provides this activity that's important for providing us with a normal B cell repertoire. So just like T cells, the B cells that can bind to self appropriately are being maintained, and those that bind to self too tightly are being killed by apoptosis. But you change the threshold for the binding by changing the way the signaling is occurring, and you keep some of these cells that can bind too tightly, and then you're retaining cells that might result in autoimmunity. And so we call this central tolerance, where we have positive selection to try to maintain the cells that can bind just right to self and the self HLA, and negative selection to get rid of the cells that are binding too tight to self that could cause autoimmunity. And so the process is the central tolerization is to keep the ones that are just right. And this is the normal way we prevent autoimmunity from occurring. But not everything is being removed. And so we end up having peripheral tolerization to help provide us with extra steps. I don't have time to go through all these processes, but just suffice it to say, we have several mechanisms to try to prevent the cells that make it through the central tolerance process that can cause autoimmunity to try to control those. And for the most part, these are controlled. The only dilemma is that sometimes that we come up with a viral infection like Epstein-Barr virus, chemicals, mutagens, radiation, other things happen to us that offset this balance and then allows those cells that were being controlled by the peripheral tolerization to actually become active and result in autoimmune disease. Again, this can happen to anybody, whether they have immune deficiency or otherwise what we call normal immunity. And so all of this is some form of counterregulation, and some of the peripheral tolerization and our normal immune system function is a balance to maintain homeostasis, to create a balance to prevent over exaggeration of the immunity or under functioning of the immunity. If our immunity skews towards what we call Th1, Th17 T lymphocyte immunity, that promotes inflammatory autoimmunity, such as arthritis conditions. And I'm going to go over this stepwise to give you a hint and then go over it again to help better explain what's going on. So we start with that CD4 T lymphocyte that migrated from the thymus, that underwent the positive negative selection, and it is a naive cell because it has potential to bind something that's not self, but it hasn't run into that yet. And so what happens is a foreign antigen is being presented by an antigen-presenting cell and releases cytokines, again, IL-12, IL-18. And in that case, and if you recognize that peptide that's being presented, this becomes what we call a Th1 cell that's used to fight off viruses or what we call intercellular parasites. And these are inherently inflammatory. On the other hand, if the peptide that the naive cell is binding to and interacting with and receives IL-4 signaling, it will make the T cell become a Th2 type T cell, which provides antibody production and antiparasitic protection and is inherently anti-inflammatory. And indeed, these are very important to help counter-regulate each other. And so this helps, the Th1 helps prevent us from developing allergies, and the Th2 help calm down the immunity to try to prevent things from rheumatoid arthritis from occurring. And I'll explain that more in another slide. On the other hand, if the peptide that's binding to causes the antigen-presenting cell to produce TGF-beta and IL-6, we produce what's known as Th17 cell. This fights off extracellular pathogens and fungal disease. And these, again, once again, are anti-inflammatory. So we have intracellular, like viruses, extracellular, like fungi and bacteria, and antibody production. But we also have the production of what are called T regulatory cells that are part of that peripheral tolerization process. And if it recognizes an antigen that's associated with self, it produces TGF-beta from the antigen-presenting cell, makes it a T regulatory cell. The T regulatory cell produces what we call anti-inflammatory cytokines to calm down the immunity that's occurring with the Th1, Th17. But we don't want to calm things down until the infection is cleared. And so as long as the Th17 are active trying to fight the infection, it's keeping the Tregs from activating. And once the infection is clearing away and the Th17 start self-calming down, the Tregs then come into play to help calm things down more quickly. And I'll show you that in the next few slides. And so we are programmed at birth for Th2, for parasitic protection, antibody protection. When we're born, evolutionarily, our mothers would pick things up off the ground to feed to us, and that would give us parasites. So we need parasitic protection. In the modern world, because we're not exposed to parasites the same way, this results in a lot of people having allergic disease rather than providing protection. If you live in a third world country, you tend to have parasitic protection, or if you live in a first world country, you tend to develop allergies. But if you drive this to the extreme, we end up with conditions such as lupus, dermatomyositis, and related small vessel vasculitides. Th1, once again, are there to help provide us against parasites, intercellular viruses, mycobacteria. And when they're driven to the extreme, especially in conjunction with the Th17, result in rheumatologic conditions like rheumatoid arthritis, psoriasis, ankylosing spondylitis, psoriatic arthritis, so all those types of arthritic conditions, graft rejection. And so these are very inflammatory when they're driven to the extreme. The Th17 provide the extracellular protection, so against fungal and bacteria, and are playing also a role in autoimmune conditions like rheumatoid arthritis and graft rejection. And the Tregs are producing IL-10 and TGF-beta to try to downregulate and cause tolerance induction. And so these various cytokines counter-regulate each other to try to create a homeostatic balance. And so when one gets activated up, the others activate up to try to control it. And so let me sort of explain that. So if we're having allergic type disease where the Th2s are being overactive, the Th1s produce interferon gamma to calm them down. Likewise, if we're having too much Th1 activity, so we're having too much fighting of viruses or we're trying to develop rheumatoid arthritis, the Th2 release IL-4, IL-10 to try to calm down the Th1. The Tregs produce the TGF-beta and IL-10 to try to calm down the activity of the Th1 and Th17 when they get overactive. And likewise, the Th17 produce IL-6, IL-21 to calm down the Tregs to allow it to complete the infection and allow you to control the infection before we calm down the immune system. So this counterregulation normally helps maintain a homeostatic balance to prevent too much inflammation or too little anti-inflammation. And this balance is there to try to maintain its homeostasis to prevent autoimmune manifestations from occurring. If the T lymphocytes bind too tightly, or we haven't eliminated the ones that can bind self tissue, then we can result in autoimmunity. And so this we call quality control. And so that quality control that I was mentioning earlier with the positive negative selection and the T and B lymphocytes plays a major role in trying to control what's going on and prevent problems from occurring with autoimmunity as well as immune deficiency. We make millions of different lymphocytes every day, and we have to depend on that quality control to help prevent the immune processes from creating dysfunction and going awry and creating autoimmunity or immune deficiency. But if we have impaired immunity up front, sometimes our immune system will sort of guess that it can hold on to some of the cells that are on the borderline. So, for example, if somebody has a 32-inch waist belt for their pants, this immune system will hold on to the 31-inch and the 33-inch to say they're close enough to 32 that maybe they could provide us with some benefit. Where if you would otherwise have normal immunity rather than immune deficiency, we'd eliminate the 31 and 32-inch for the potential for causing problems. And so they're maintained even at the risk for autoimmunity because the immune system thinks that its peripheral control mechanisms can help maintain the balance. So this compensation process pertains sometimes to useless ones and too tight binding ones. And unfortunately, this causes a waste of energy if they're useless. And then we use up a lot of energy, and that can make people unwell. And if we retain the too tight binding, we end up with autoimmune disease. B lymphocytes, I keep mentioning, are playing a role in what's going on and play a major role in everything. Even initially, it was thought that it was a bystander effect because they were activated by T cells, and if T cells didn't activate them correctly, then that was the problem. But now we understand that the B lymphocytes can make autoantibodies if they haven't been selected for correctly, and they play a major role in presentation of antigens that the autoreactive T cells are acting against. And so to summarize what we've been talking about, that the development of normal immunity tries to eliminate the useless and the autoreactive antibodies in T lymphocytes in order to maintain a repertoire that has potential to find and recognize foreign peptides in order to react against those to provide us with the protection against infection. Control mechanisms do a reasonably good job of this. So central tolerization with the positive negative selection and the thymus, so it maintains the ones just right, getting rid of the useless too tight binding. And the periphery having that balance with the cytokine balance, trying to maintain homeostasis to prevent overreactivity and underreactivity. But unfortunately, if you've inherited genes that promote the incorrect threshold for signal transduction, then it allows for cells that otherwise should be eliminated by the negative selection processes to be maintained. And the maintenance of these can allow for them to become activated under certain circumstances and then respond to self. And so chemicals, irradiation, certain viruses, we now know, for example, the Epstein-Barr virus causes lots of autoimmune diseases. Epstein-Barr virus may be a major cause for rheumatoid arthritis, diabetes, and multiple sclerosis. Other viruses like measles may be responsible for causing diabetes. A parvo B19 causes aplastic anemia and thrombocytopenia. So the viruses trigger the immune system to go haywire and start responding abnormally if you've inherited the correct HLA components and you have the wrong genes that have the wrong threshold for reactivity that allows this process to promulgate itself. And then patients with immune deficiency may be a little bit slightly higher risk because there may be this tendency to try to maintain some of the cells that otherwise would be eliminated because they're just slightly out of the normal kilter. And the immune system says, I think I can control those. But unfortunately, a virus may overcome that control mechanism. And then the genes that are responsible for these things may be the most likely cause of problems occurring. And that's, again, why we're moving now to the term of inborn error of immunity, rather than just thinking of things as either immune deficiency or autoimmunity. And then, unfortunately, if there is an immune deficiency present. The imbalance of the cytokines, the signal transductions, may make it more difficult for us to control the autoimmune process that could be occurring there. And B lymphocytes may ultimately be a main enemy in both immune deficiency and autoimmunity. They can produce antibodies that provide us no benefit. They can produce autoimmune antibodies, and they can present antigens that stimulate the T lymphocytes to start an autoimmune disease process. And so to help treat these, the first thing we need to do is maximize our immunoglobulin replacement therapy by considering giving higher doses of immunoglobulin or more frequent dosing. And I know in Canada, because I helped other patients with this issue, that the primary care sometimes can't do this. And even the specialists sometimes have a hard time. And what we've had to do is write letters or speak to the specialists to say it's okay to give a higher dose of immunoglobulin. And all you have to do is tell the National Health Service that it's needed to control the immune deficiency and autoimmunity in this patient. And also, we now know that given rituximab, which eliminates B lymphocytes, may be a very important way of taking care of both issues. By eliminating the B lymphocytes that are creating problems, both for immune deficiency and autoimmunity, we might be able to control both of those conditions much better, especially if we've optimized our immunoglobulin replacement therapy. At this point, I'd like to stop and thank you for your attention and answer any questions that you may have asked.
Well, thank you so much, Dr. Harville, for this incredible presentation. I have learned so much from you. Please, everybody, just enter the questions that you might have in the chat. We had some that came through, so I'm just gonna, while we start, where I'm gonna read them. Small reminder that we will try to get to all the questions today, but if any, we are not able to get to all of them, Dr. Harville has kindly agreed to answer any of those through email. So I'm just going to just go share a little bit of my screen here, just to go back to that Q&A. There you go. So right now we are at the Q&A question. So I have the first one. Oh, I think that I had one exactly. Give me 1 second, because I think that I have one here that I can read out loud. Please comment on the interplay of frontal fibrosing, alopecia, and CVI. I have these both, and I am wondering if the alopecia can ever be overcome and that treatment can be successfully discontinued, or is it a forever problem that will have to be managed, as is the CVID? Thanks for your response, Dr. Harville.
That's a very interesting question. I can tell you that we've treated patients with rituximab that have alopecia and alopecia areata and alopecia totalis that developed with CVID. And so they were diagnosed with CVID, and over time they started losing their hair, and we were able to use rituximab to help with the process. Once again, would maximize the dosage of the IVIG, and one of the patients I'm speaking of that we did that with, we had to push the IVIG dosage up from the 0.5 gram per kilo, and eventually had to have it at 1 gram per kilogram per month, and gave rituximab, and after several doses of rituximab, was able to start having the hair grow in.
Thank you for that answer. I have another question here. It says, I have been told that I have a primary immunodeficiency and an autoimmune disease, rheumatoid arthritis. I'm a little confused about the EAI wording. Are you saying I no longer have both? Do I only now have one thing? Are they both an EAI?
Both are there, and that's the issue that has why this was always confusing in the past, because people would say rheumatoid arthritis, high immunity, CVID or antibody deficiency, low immunity. Wait a minute, how can I have high immunity, low immunity at the same time? And that's why we now know that those concepts are incorrect. It's immune dysfunction that's present, and the immune dysfunction results in both having rheumatoid arthritis and antibody deficiency or immunodeficiency at the same time. We've had several, just to point out for this, had several patients with this again, and the control has been giving IVIG a gram per kilogram every 2 weeks IV. That has controlled the rheumatoid arthritis as well as the antibody deficiency.
Thank you for that. I have a second question, another question, sorry. Can an autoimmune disease delay a diagnosis of primary immunodeficiency?
Yes, and I'll give you all an example of that. Is there was a girl who started having Crohn's disease at about 10 years of age, and around age 13 or 14 was noted to be having lots of infections. They were being attributed to the immunosuppressive therapy being given for the Crohn's disease treatment. And in passing, one of the gastroenterologists just happened to mention, I said, did you check their antibody levels? And they said, no. I said, let's look at their old test results. We looked at what was called their total protein value and their albumin back when they were diagnosed with Crohn's disease and found out the gap was very small. And the total protein is a combination of albumin, gamma globulins primarily, and if you subtract the albumin, you should see about 3 grams per deciliter. And her value was about 1.1 gram per deciliter. So when she was diagnosed with Crohn's disease, she already had antibody deficiency that was unrecognized, but wasn't creating any adverse infections. After about 4 or 5 years of treatment is when she started having infections occur, and then had a formal workup for an antibody deficiency, and the diagnosis of CVID was made. Got placed on IVIG, and both the infections went away, as well as there's tremendous improvement in the inflammatory bowel disease, so that she could stop the inflammatory bowel disease treatment. And I've heard this story over and over again. If you look my name up and you look for some of these concepts, I've written book chapter 6 that will describe these scenarios.
Thank you so much. I'm gonna read another question that we have live here. So do I understand that my lymphocytic colitis and rosacea is caused by my primary immunodeficiency?
Well, they're probably running in parallel. Not exactly. There may not be a direct cause effect relationship. The immune dysregulation that has resulted in the immune deficiency may be contributing to the immune dysregulation that's resulting in the lymphocytic disorder. And the same gene may be responsible for both of these conditions. Once again, I'm sorry, Andrew, once again, maximizing the immunoglobulin replacement therapy usually is the treatment of choice to help deal with these issues.
Thank you, Dr. Harvell. Another question, how common is it for an immunodeficiency to hide an autoimmune process? Am I right to understand lack of antibodies can therefore fail to trigger the failure in blood test?
Yes, and so that's a very good question, and it can vary widely, and depends on what type of how severe the antibody deficiency is. And so, in general, we may test for an ANA to see if it's there, but we don't see the absence of detection as proof that the disease is absent. And so we look at the patient to determine whether the disease is present based on the clinical symptomology and the total aggregate of the blood tests that are being done. So the blood counts, liver function tests, other things that can be utilized to help us diagnose what's going on. If there's a certain type of rash present, we may use a biopsy to help diagnose the type of vasculitis that could be present that could be causing a problem. Sometimes it might require doing a biopsy of a kidney or a biopsy of lung tissue or biopsy of sinus tissue to look for vasculitis that can't be detected by normal antibody tests that can be utilized. So we don't not look. So sorry for the double negative there, but we will use the antibody tests that are routinely performed to see if they will confirm it, But if they don't confirm the diagnosis, we don't use that as an excuse saying that the disease is absent.
The next question, I really love this question because I have thought about it too long ago. Lauren says or asks, what happens if the thymus has been removed?
This is of grave concern. And so, years and years ago, when infants underwent cardiac surgery, the thymus covers the entire heart, and the heart in a tiny infant will be the size of a walnut, for example. And the surgeon is having used magnifiers and microscopes to look at the small vessels and so forth to try to repair the damaged heart because of abnormal development. And so they would just cut the thymus out and remove it. Fortunately for me, these kids, by the 16th week of gestation, we've developed our T cell repertoire that we need to last a lifetime. And so, and for some of the people who are lucky, and if they lose the thymus, the repertoire is still there to give them protection for the rest of their life. But they're giving chemotherapy, they're giving something that depletes them of their T lymphocytes, irradiation. They have no ability to create new ones. Likewise, if their T lymphocyte repertoire they developed in the fetus was incomplete, then this new virus that comes along, for example, like the pandemic we had with SARS-CoV-2, you may not have a T lymphocyte around that can provide you protection for it. So for these infants and those that are born with a condition we call DeGeorge syndrome, where the thymus fails to develop, we undergo thymic transplants. So back in the early 90s, when I was still at Duke University, Dr. Louise Markert pioneered this process, and I was fortunate enough to help her do this. And we take thymuses that were being removed from infants that were undergoing heart surgery, and we cautioned the surgeon to not remove the entire thymus, but leave part of the thymus present so it can regrow. And we take the thymus they would remove, we'd cut it into tiny little slices. We would then incubate it to remove any mature T lymphocyte that might be present that could cause graft versus host disease. And then we would make an incision in the infant that needed the thymus in their thigh muscle and place this tissue from the thymus right next to the thigh muscle so it can get blood vessels and get blood vessels to grow into it. And then that would allow the normal cells produced in the bone marrow from the person to then migrate to the thymus to undergo thymus selection processes. Initially, there's a bottleneck because there's very little thymus there, so it takes time for them to fill up the repertoire, to fill up the tank, as it were, because they have to go through lots of times. It takes a long time for the T lymphocytes to travel through and develop in this process. But eventually, over several months to a year or so, they would then develop their full T lymphocyte repertoire. So we can transplant thymuses in those patients that need one.
Another question. I love that we are getting lots of questions. It's really, we learned so much from all of them. Are there any specific protocols for, and I apologize for my pronunciation, for rituximab in CVID patients or other inborn errors of immunity with autoimmune comorbidities such as
Yeah,
cytopenias?
yes. And so generally, it's given usually that the first month, we give 1 gram per meter square of rituximab each week. And I usually follow that a day later with 1 gram per kilogram of IVIG. And for example, in the situation you're just defining where somebody has cytopenias, like they're severely thrombocytopenic, their platelet count is extremely low, or other white blood counts or other cell counts are very low, and they need replacement of these. After the first month, then we usually do it twice a month for 1 to 3 months, and then once a month until we get the benefit we need. And usually we start seeing benefit within the first few doses of this.
We have just a little bit of time just for one more question. We apologize for in being able to get them all, but as we said, Dr. Harville will he kindly agreed to answer them through email as well. And you can always reach out to Immunity Canada for more information. One of the questions, how common is chronic leukemia in association with CVID as opposed to acute leukemia? If it's associated, is it treated with IVIG?
So the most common chronic is called CLL, or chronic lymphocytic leukemia. And off the top of my head, I'm sorry, I can't give you exact numbers for how common. It's it's not that rare, but not that common either. And there are now specific inhibitors of the genes that are responsible for those conditions. And generally, we give IVIG at a higher dosing, plus that inhibitor in those patients that have the CVID. Further, I like using RAV in those patients in addition to try to remove all of the malfunctioning lymphocytes. And likewise, with the acute leukemias, I like using the rituximab in addition. But usually nowadays we have specific inhibitors like ibrutinib and so forth that can also further inhibit the abnormal B lymphocyte function that's causing the leukemia effect. And so we'll give higher doses of IVIG, give rituximab, and give something like ibrutinib to help control the process.
I think that we
Yeah,
have time for one more. Are there any gene therapies that can help with immunodeficiency or anything coming that are being tested?
that's very, very interesting question. For SCID, Wiskott-Aldrich syndrome, chronic granulomatous disease, and now leukocyte adhesion deficiency, all have had specific gene therapies applied and tried and worked in many of the patients. The gene editing process with CRISPR has been utilized and works too. CVID, the problem is that only about 1/3 of the cases, 25% to 30% or so, can we actually find a gene that's responsible. So currently, most of the genes that are responsible for CVID are multifactorial. So we're dealing with multiple genes that additively are creating the problem rather than a single gene problem or a single gene that we haven't identified yet. So for CVID, we don't have gene therapy yet. In the future, possibly, but that's something that I don't see happening in the near future. May have
Perfect.
another one or two.
I think one more. Any experience with using serial, I have the name, sirolimus with
Sirolimus.
error of immunity patient with autoimmune.
Yes. And sirolimus or sirolimus, however people pronounce it various different ways, is one that can help sort of part of the immune abnormalities, the IEI, so inborn errors of immunity that are overactivity of immunity that again seems to be contradictory, that results in immune dysfunction where immune deficiency is present, but yet the immune system is overactive. And sometimes medications like sirolimus have been able to be put on board and help calm things down so that the immune system is working more functionally normal now. And so we have patients that are on IVIG and sirolimus that seem to be going along more normally now. Most of these patients will have some kind of what we call lymphoproliferation. So their lymphocyte count goes way up and their lymphocytes infiltrate their tissues. Lymph nodes get big, their spleen gets big, their liver gets big, and so forth.
Perfect. Well, thank you so much. I'm gonna share my screen here. Thank you so much, Dr. Javier, for this incredible round of answering our questions. Thank you all so much for everybody for attending. We really hope that all of you just learned as much as we all did and to share widely the lots of the knowledge that we got today. I hope everybody joining, well, stay tuned for our fall sessions, webinar sessions as well. And if you have any other questions, please email us. And yeah, as I mentioned before, well, Dr. Javier will happy to, well, kindly agree to help us answering a little bit more of them. We really just love having all these events for all of you and to joining us. I hope you all have a lovely night. And this is a couple of our info at immunitycanada.org. And follow us and just stay tuned for more webinars with us. And thank you. Thank you all.
Thank you very much.